SEARAC, and then we'll move on to remarks from Vattana Peong, who is the Executive Director of the Cambodian Family Community Center. And then afterwards, we'll do a quick one-on-one about Southeast Asian American health and policy and the current policy climate. And then after that, we'll spend the rest of the session focused on, tips and basic skills for engaging with members of Congress or with their staffers before breaking out into small groups to give you an opportunity to put a meeting together. And then if we have time, we'll do 1 or 2 mock legislative meetings with folks who are present. And if you have questions, feel free to unmute yourself and just ask or throw them in the chat box. I'd like to keep this as informal as possible. I think it's a nicer, it's a bit more, it'll break the pace of the Zoom webinars that I've been part of for the last few months. So my name is Kam. I am the Director of National Policy at the Southeast Asia Resource Action Center. I am a gay, Hmong American, cisgendered male, and I was born in a Thai refugee camp 31 years ago. I have over a decade of community building, policy advocacy, and lobbying experience. And I've worked in a variety of different areas, specifically with a focus on technology and telecommunications policy and immigration policy prior to becoming SEARAC'S Director of National Policy. In this role, I'll be handling the bulk of our health policy portfolio and working with the rest of the DC and California policy staff to expand our work and our influence in DC amongst legislatures and in the administration. To give a little bit about background about SEARAC, we were founded in 1979 to help pass the Refugee Resettlement Act and then subsequently help resettle Southeast Asian refugees into the United States. Since then, our policy work have focused broadly in 3 areas: education reform, health reform, and immigration reform. In health specifically, our work is focused on disaggregating health data, increasing in-language support, increasing access to healthcare, and funding culturally competent mental health. So up next, I'd like to introduce you to Vattana Peong, who is the Executive Director of the Cambodian Family Community Center, a 40-year-old nonprofit, multi-ethnic human services agency providing preventative health, mental health, youth and resident leadership and education, civic engagement, immigration and cultural preservation programs to low-income children and families in the Orange County, California. Vattana has over 17 years of experience working with nonprofit organizations, both in the United States and abroad, and has been a strong advocate for mental and public health equity. Vattana is also currently serving on 2 county committees as the co-chair of the Cultural Competency Committee for the County of Orange County Health Agency's Behavioral Health Services and Orange County's Healthier Together partnership. He is also a member of the State of California's Cultural and Linguistic Competence Committee of the Mental Health Services Oversight and Accountability Commission. Vattana, I'll hand it over to you.
Thank you. Everyone can hear me? Good? Great. Good afternoon from California. I know that everyone is from all over the country. So good afternoon from California. It's about 2:40 in California. Again, my name is Vattana Peong. I am the son of Cambodian genocide survivors and the executive director of the Cambodian Community Center, a multi-ethnic community-based organization founded in 1980 and based in Orange County, California. Thank you so much for having me today. To start, I just wanted to thank for this opportunity, and also I want to provide you with a brief background regarding health barriers in the community we serve. Orange County, California has a population of over 3 million people. Orange County is the 6th most populous county in the US. And there are about 8,000 Cambodians living in the county. That is according to the census 2010. And we know that our population was undercounted. We know there are over 10,000 Cambodians. So census 2020, don't forget everybody, will be a golden opportunity to push for everyone to get counted for that. And our Cambodian community started to, our Cambodian community that we serve started to resettle as refugee in Orange County in 1980. However, despite living in the county for nearly half a century, our community continues to struggle with social inequities and the lack of access to culturally and linguistically competent health and mental health services. We know it from the data that 62% of the community members that we serve were diagnosed with post-traumatic stress disorder, PTSD, and 51% diagnosed with major depression. And there are so many barriers for our community in accessing the preventive and healthcare services. And that include the lack of knowledge and awareness due to the lack of targeted in-language outreach education for our community, the lack of culturally, linguistically competent services and service providers, transportation barriers, and last but not least is stigma around mental health and cancer, particularly breast cancer in our community. There is a lack of knowledge and awareness regarding available health and mental health services in our community. For example, in the county that we provide services, Orange County, there are over 200 mental health programs and services. However, over 80% of the community we serve were not aware of that services, was not aware of that program. And that is due to language barrier in terms of accessing the services. And that due to the lack of targeted outreach and education to the different community. The system that we have tend to put Asian Pacific Islander communities as one group, frequently known as API, but it does not recognize the diverse ethnic groups or subpopulation within the API, like Cambodian, Hmong, Vietnamese, and other communities. And each culture is different, and culture is a big part of their health. And that point out to the lack of the disaggregated data. Also, there is a stigma around mental health and cancer, particularly breast cancer, that serve as barriers to seeking help. For example, in the Cambodian community that we serve, the community believe in karma. And when someone has some health or mental health challenges, they're more likely to seek help from the Buddhist monk. And one of the cultural practices is to receive water blessing from the monk to splash away the bad karma that they believe from their past life, that they have inherited that, and that's why they're not feeling better. And those kind of practices we call community-defined practices. And that community-defined practices that recognize what works and what doesn't work in a particular community and uplift the value of our community. So as an organization, we have incorporated that cultural practices in our mental health outreach and education that help to increase awareness and also encourage people to seek help. So if the system doesn't have that type of understanding within our community, so even though they have great program, that program will not reach our community. And another issue is the lack of providers with an understanding of the patient culture. In all Orange County, believe it or not, we have about 8,000 or 10,000 Cambodian, but there is only one Cambodian speaking medical doctor that is located very far from a community that most of our community live. So if you are looking to seek for a Cambodian speaking medical doctor, you have to take 2 or 3 buses, about 30 to 40 minutes to access the healthcare that you feel confident or comfortable receiving with. But most of the community that we serve have transportation barrier, and that could be the reason to prevent them from accessing the healthcare services. And you may want to do quick research within your community to see how many doctors who speak your parents or your grandparent languages in your community. That is so important because accessing that services is right in the community. And if that's not possible, that is a major barrier and a huge health disparity. And a few years ago, there was a huge mental health disparity that has led me and my team to increase our effort in mental health equity and advocacy work. We have a mother of two teens who were removed from her, and she was ordered by the court to receive mental health counseling services before the court could consider offering her the custody back. She then reached out to us for help to get a Khmer-speaking mental health counselor so that she could be reunited with her family. However, we have only two Khmer-speaking mental health counselors in the whole county, but those counselors require her to be severely diagnosed with mental illness in order for her to qualify. But she just needs a therapy session. She just needs somebody to talk to in her own language. And she's not just about coming here, and she's not receiving a severe mental health diagnosis yet. So that she could not access that services. And we kept searching and searching, and we had no one. So the last resort was that we connected her with a Spanish-speaking mental health counselor. And I asked one of my staff to provide interpretation during the counseling sessions. And there was things that she did not feel comfortable sharing through the interpreter. So with her limited English, she decided to communicate directly with the counselor. However, I think by the third or the fourth session, she dropped out. She then came back to us, and we have talked to the court about her challenges in getting a mental health counseling in her own language. And then the court agreed to have her referred to another county, which is Los Angeles County, where there is a private practice that has a Khmer-speaking mental health counselor. The court paid for it. Unfortunately, she did not drive, so she had to take 3 or 4 buses to get from Orange County to Los Angeles County to just receive one session every day. Remember, she is a taxpayer in Orange County. She lives in Orange County, but she could not access the services in her own county. This is just one of the many stories that we have heard through our work. And because of the struggles that our community has faced and continue to face, my team and I, together with our partner, has increased our effort and engagement in mental health advocacy at the county and at the state level. How do we do that? We still have a community that is older. The majority of our community that we serve are 50 and older, and about 30% are 60 and over. And is still suffering from PTSD, a community that is still fearful of the government because of their past experiences with the government in the country that they were originally from. So first thing that we needed to do is to build their capacity and confidence in doing the advocacy work. So we created a program called Community Ambassador Leadership Program, which aimed to increase resident leadership and advocacy skill so that they themselves can advocate for policy and system change, accessibility, and also quality in the mental health services in response to the community. And what are the solutions that we have do that? So the solution to the issues is simple. It's called community ownership that has been included in many of our work at the Cambodian family. So you have the community ownership, and once you have the community ownership, that leads to informed decision makings, which in turn lead to the program and services that are responsive to the needs of the diverse community member. Community ownership means being at the table, being able to participate, to engage and advocate and voice your opinion and input at different platforms, and to make sure that the system under their need. For example, like I mentioned earlier, if the system doesn't understand or doesn't recognize the cultural and the barriers, language barriers that our community face, even though they have these 200 programs and services that are available. We're not talking about limited resources. They have a lot of resources, but the resources do not come down to the community. So the community ownership, we allow them to hear directly from the community to be able to do something that are responsive to the community that they serve. And And that is important. And we also increase our effort in ensuring that our community participate in every session that the county has put forward to get the feedback from the community about the program that they want. And to have the community ownership, we need to work on increasing resident leadership and advocacy skill, like the community ambassador leadership program that we are implementing at the Cambodian family. We need to work on increasing opportunities for residents to civically engage in their community by ensuring that transportation, language, and time are not barriers to the participation. And also we need to work on increasing awareness of the issues within our community in regard to the health disparity with the system and also within our organization and also with the community in general. And lastly, we need to work on mobilizing and engaging our limited English proficient in advocating for the health policy and services that are responsive to the community. I would like to share also some of the successes regarding our community ownership solution. Because of these empowered ladies or residents, a lot of participants are female, so we spotlight them in this photo. You can see because of them being at the table, they were able to have their mental health need reflected for the first time in 40 years resettling in Orange County in the county 3-year mental health plan. And that is a big thing. It's mean that you are visible once your needs are identified in the plan document. And then it's mean that you are there, you are not forgotten. And also they were able to advocate for language access for monolingual and limited English proficient community like the Cambodian community at county meeting and public forum. And also more importantly, for the 40 years, they were able to receive the first funding of $37,000 from the county to provide mental health services that are uplifting the community-defined practices like water blessing, gardening, yoga, and those kind of things that are working in the community, that the community know it's working to be provided to the seniors. And another solution to the issue is, like I said, there is a significant lack of culturally linguistically competent mental health provider or healthcare services provider. So we need to have a diverse workforce from the community who look like us. So there is the need to be a high school, college, and career pipeline that help our youth become in the professional that are lacking in their community, such as clinical social worker, marriage and family therapist, doctor, and more. For us, like we try to recruit a licensed clinical social worker who are bilingual by culture. We put our job announcement. 6 months later, we got 0 applications. And that is a significant lack of the diverse workforce in our community. And lastly, since we are right now in the pandemic, I would like to bring your attention to some of the impact of COVID-19 on our organization and the community. As you know, COVID-19 has really impacted all of us. And for us as a nonprofit, we have experienced significant impact on our organization, operation, and sustainability. We have canceled all of our in-person program and services and classes. We've been offering services through telephone, online platforms like Zoom, YouTube, Facebook Live, tele mental health, and census-borne banking. And I'm so proud of our staff and other staff from different nonprofits that they have been very quickly able to adapt themselves to these changes and have done an amazing job in supporting the communities during this unprecedented time. Over the past 6 months, our organization, in partnership with other community partners, have provided information, resources, and services through more than 4,000 check-in calls, 2,700 case management services, which increased by 500% from before the pandemic. And also, more importantly, to teach our older adults how to use technology such as Facebook, Zoom, because about 34% of our clients, they use the flip phone. So if you talk about technology and access to those classes, it's almost impossible. So we have to make sure that those seniors, especially 55 and older, have access to technology and also technology equipment as well. And And each call, check-in call with the community, we talk to them. We have gathered a top 5 need. Those needs include assistance with paying rent, paying utility bills, obtaining food, completing unemployment application, and also benefit enrollment assistance such as medical and food stamp. So we have seen a 600% increase in terms of our medical and CalFresh, or we call food stamp application in community. And we continue to be responsive to our community by providing in-language COVID-19 education, testing, navigation, and resources, and responding to our COVID-19 related question from our community, especially the monolingual community. So these are the impact that we have been dealing with. And my last message to all of you is that be at the table, be engaged, be included, and be seen. If you are not at the table, someone will take your seat and decide that for you. Connect with your local elected official to advocate. Connect with your local CBOs to see if you can join their forces to advance health equity, either advocating for data disaggregation, language access, culturally and linguistically competent workforce, or community ownership. So again, be at the table, be engaged, be included, and be seen. And thank you so much for your attentions.
Thank you so much, Vattana. We have 2 minutes if folks want to ask Vattana any questions, or if folks have any comments or things that they just want to pick his mind about. Well, if there are no questions, Vattana's information is on this PowerPoint right now. We'll chat his information over to folks if you all want to follow up with him. But thank you so much, Vattana. And you're welcome to join us for the rest of this or bounce. Totally up to you.
Thank you so much for my contact information. Thank you.
Thanks, Vattana. So as Vattana had mentioned, Asian Americans are oftentimes discussed as the most wealthy and educated racial group in the country. And without providing adequate data to this community and the nuance that they deserve. And he mentioned that aggregated data aggregated AAPI data masks the actual realities that Southeast Asian Americans face. In health, most state and federal health systems fail to tease out data on Southeast Asian Americans from the overall Asian American category, making it difficult for us to understand the rich diversity of the Asian American, Native Hawaiian, and Pacific Islander languages, cultures, and experiences that carry wide variation in health needs. For example, the traumatic experiences of war, genocide, and displacement left many Southeast Asian Americans with physical and mental health conditions that have gone untreated and are oftentimes masked because we don't have accurate data to really make the case for why we need additional funding or additional programming for our communities. And this mass collective trauma and the stressors associated with relocation, including English language difficulties and cultural conflicts, continue to affect the physical and emotional health of many Southeast Asian refugees and their children. And while Southeast Asian Americans were resettled in the US decades ago, many of us still continue to live with unique barriers and socioeconomic challenges. As we think about how policy can help make ourselves and our communities healthy, we must understand that quality healthcare is only one component of a healthy person. A person's health will deteriorate if they're not able to be economically secure or have access to food. Whether or not someone graduates from high school is an indicator of whether or not they'll be able to make healthy decisions as an adult and keep a healthy status. And if someone doesn't feel safe in their home, in their schools, or in their communities, it also impacts their health. Likewise, not having access to the internet at home currently impacts the health of individuals during this pandemic, because folks are not able to access telemedicine, and have to go into their urgent care or their doctors rather than taking the initial visit online. I think it's oftentimes we don't often talk about it, but we know that 10% of Cambodian households don't have the internet at home or don't have broadband internet access. And so these populations struggle more than others to be able to fully access their healthcare services and healthcare needs during this pandemic compared to other populations that have more readily available internet and technology access. And so the social determinants of health framework that you see here challenges us to look at health more holistically. It's part of the reason why SEARAC believes that issues like racism is detrimental to our collective health, because it impacts the type and the quality of care that communities of color have access to, even if they have health insurance. Next slide. So to just give you a really quick overview of the sort of poverty and the health insurance coverage landscape among Southeast Asian Americans, as you can see here, based on the latest 2019 American Community Survey, the Southeast Asian Americans generally still have higher rates of poverty than the total American public, with Hmong Americans and Laotian Americans having a higher poverty rate at about 11% for Hmong Americans and 12.2% for Laotian Americans. That said, Cambodians, Hmong Americans, and Laotian Americans all use SNAP at a higher rate than the average American population. And then we also have, about 30% of our community has public health insurance, that being Medicaid or Medicare, and about 36% of Hmong Americans have public health insurance. You'll notice that the uninsured population for Southeast Asian Americans is actually relatively low, lower than the total American average. And this is a direct result of the Affordable Care Act, which in its aftermath cut uninsurance rate among Southeast Asian Americans by half. One thing to note is that despite the fact that our uninsurance rates are relatively low now, they've actually increased from 2018 by amongst all Southeast Asian populations by about a fraction of a percent, aside from the Laotian population. And it's similar with the total American population as well, in that we now have more uninsured people than we did a year ago, which is particularly devastating during a global pandemic. So as we had mentioned, the API community is extremely diverse, with about 43 different ethnic subgroups who speak more than 100 different languages and dialects. As such, language barriers make it difficult for Asian Americans and Southeast Asian Americans to access regular healthcare and mental health services. And like Vattana had mentioned, discussing mental health concerns amongst our communities is still a taboo. And as such, our communities oftentimes dismiss, deny, or neglect their symptoms. Despite that, nearly 1 out of 2 Asian Americans have difficulty accessing mental health treatment or services because they are limited English proficient or are unable to find services that meet their language needs. So if you look at the chart, which again is pulled from the latest, from the relatively recent 2019 American Community Survey, the Southeast Asian American population has a much larger percentage of limited English proficient individuals than the general American public. So we have 8% of the American public that's LEP, and then we have 29% of Cambodians, 27% of Hmong Americans, 28% of Laotian Americans, and 44% of Vietnamese Americans who are limited English proficient meaning that essentially we have about a third of our communities who cannot access, who have trouble accessing healthcare services unless they have in-language support. And like I mentioned earlier, the refugee experience has been particularly traumatic for our communities, and Vattana had mentioned it as well, but it's left long-term mental health issues for our communities. According to the Center for Disease Control and Prevention, in general, Asian Americans typically report fewer mental health concerns than white Americans. However, there have been multiple reports that have found high rates of distress amongst refugee youth and older adults. For example, one study found that Cambodian high school students had symptoms of both PTSD and mild but prolonged depressive symptoms. And researchers have also noted high levels of anxiety amongst unaccompanied minor, adolescents, and young adult refugees from Vietnam as well. Back in the late 1980s, early 1990s, and many of this still remains untreated. Likewise, in a study of Cambodian adolescents who survived the Khmer Rouge, they found that nearly half suffered from PTSD and 41% experienced depression approximately 10 years after the traumatic episode. And we've also heard from multiple Hmong American mental health counselors in the Sacramento area who have said that 90% of their patients are Hmong, and that the most common diagnosis amongst elders are PTSD and major depression. Similarly, a 2005 study from the University of Nebraska-Lincoln's Department of Psychology found that 70% of Southeast Asian American refugee respondents were diagnosed with post-traumatic stress disorder, and that the community also faces high rates of undiagnosed chronic illness tied to trauma, as well as contemporary living and working conditions. And if you just, and on the PowerPoint, you'll see just really quick data points related to just the number of providers available. So there are only 70 Asian American and Pacific Islander mental health providers for every 100,000 AAPIs in the US. And this sort of goes back to just Vattana's point in that there is a lack of workforce, lack of culturally competent and in-language services for mental health and for health. So health in the 116th Congress. With the election of President Trump to the White House, we've witnessed an overwhelming attack on immigrant and refugee communities, and really all communities of color. In the 4 years, we've witnessed a holistic approach to limit the access our families and communities have to critical healthcare benefits and programs. With regards to the executive and regulatory process, in order to circumvent Congress and the growing Democratic majority in the House, this president has consistently tried to attack access to benefits through the regulatory process. And unlike passing legislation that is oftentimes anchored by Congress and influenced by constituents like you, this president has been able to propose changes in how we implement laws by going through the regulatory process. And while the public can express opposition by submitting comments, it's still within the president's power and authority to change implementation guidelines as they see fit. With regards to the judicial system, since President Trump has taken office, he's successfully seated 2 conservative judges to the Supreme Court. This means that the decisions that are being heard by the highest court in the land, oftentimes have a very good shot in an outcome that is heavily backed by the Trump administration. And with the passing of Justice Ginsburg, if the Senate and the president are able to nominate and confirm a new justice prior to the elections, it would result in long-term disastrous results for pivotal cases like the ACA court case that's going to be in front of the Supreme Court in about a month. Legislatively, this president has also tried to influence the national budget. And so, every year there is an appropriations process, and the Trump administration continues to propose cuts to government social safety programs, such as Medicaid and SNAP, in order to, increase funding for the Department of Homeland Security and for the military. We've also seen efforts by this administration to shift the narrative on public health as well. I mean, we see it very clearly with the way that they talk about the coronavirus and the impact that that's had on Americans far and wide, including the changes to, the opposition to mask wearing and social distancing. We've also seen, this particular policy agenda gain traction amongst white nationalists and around more conservative evangelicals as well. But the reality is that our communities are being hurt across all branches of government because of the actions of the current president. So I want to pivot a little bit and talk about the Affordable Care Act. So on March 23rd, 2010, President Obama signed into law the Patient Protection and Affordable Care Act. Most of the major provisions of the ACA were implemented in 2014, and we saw the benefits of the ACA almost immediately. So, if you think back to the data points from near the beginning of the slide, like I said, the uninsured rates for Southeast Asian Americans decreased by half across the board because of the ACA. And part of that is because the ACA expanded Medicaid income eligibility to 130% of the federal poverty level. Basically, it increased how much income a family could have before they were ineligible for the program, which allowed, which gave states the opportunity to basically expand the program. And to date, about 30 states have expanded Medicaid. But we still have about 20 or so states who have not expanded the program. And many of these are more Republican conservative states that have a sizable Southeast Asian American population as well. Other things that the bill did was that, in order to stabilize the healthcare market, they also created the individual mandate, which was the idea that that all individuals, except for certain exceptions, had to have healthcare. Otherwise, they would have to pay a tax penalty. And this individual mandate has actually been repealed in the 2017 tax law, and by 2020, but won't be implemented until sometime this year, I believe. And then the other major component of the ACA is that it prohibits discrimination because of pre-existing conditions. So that also expanded, just the number of folks who are able to get healthcare coverage and were no longer ineligible for certain healthcare plans because of their pre-existing conditions. And the ACA also did a whole bunch of other stuff, but I'll let you all read some of those on your own. It's important to understand that if the ACA is repealed, we can expect about 29 million people to become uninsured through that process. Next slide. And so this chart just gives you a sense of the uninsurance, the Asian American and Pacific Islander populations and what the uninsured rate was prior to passage or implementation of the ACA. So if you look at the Vietnamese community, it had about 14.5% who were uninsured at the time. Laotians had 13.8%. Hmong Americans had a 13% uninsured rate. And Cambodian Americans had a 16% uninsured rate. So, the ACA has faced consistent threats from the Republican majority in the 114th and 115th Congress since its passage. And, President Trump has continued to on that message and, is part of the effort to repeal the ACA. So right now, there's a court case that's going in front of the Supreme Court that will determine what the constitutionality of the ACA. The court case was brought about by 18 Republican state attorney generals, and the Trump administration joined them in asking the Supreme Court to strike the bill down as unconstitutional. The oral arguments are taking place on November 10th, and like I had mentioned, a new SCOTUS makeup would just, very much increase the probability that the ACA could be struck down. We're expecting a decision on the constitutionality of the bill in spring 2021. But like I had mentioned, if this bill is fully repealed, if the Supreme Court strikes it down, 29.8 million Americans will likely become uninsured as part of that process. And about 1 million more individuals will also likely have to pay more or lose their insurance because of changes, because they would no longer be protected from discrimination because of pre-existing conditions. Congress, in the 116th, had tried a few different things to try to push strong messaging bills to protect the ACA, expand progressive healthcare reform policies. In 2019, House members introduced a new comprehensive legislation called the Protecting Pre-Existing Conditions and Making Healthcare More Affordable Act of 2019. They really love their really long names, so you'll see a lot of those. But essentially what it does is it lowers health insurance premiums, it strengthens protections for those with pre-existing conditions, stops insurance companies from selling junk health insurance plans, and it reverses the Trump administration's to sabotage measures to increase outreach, education, and funding for navigators to help increase enrollment in the state and federal exchanges, which reminds me that the ACA exchange is actually coming up in November and runs through December 15th. And then the other bill progressive, very progressive healthcare marker bill is called the Health Equity and Accountability Act. And if you don't know what a marker bill is, it essentially is a piece of legislation that members of Congress introduce that they're not expecting to pass, but they hope will generate buzz in media to help shift narrative and within Congress itself, so that when members of Congress are looking to introduce new legislation in the next Congress, or if they're looking to do a sort of more comprehensive bill, they have a better starting point. So that's generally how what we mean when we say marker bills. Basically, this like the most progressive you can get. This is where you should start. And HEAA is the bill, is that bill for health. So it's been introduced by the Tri-Caucus every year since 2007. And the Tri-Caucus really is just the Congressional Asian Pacific American Caucus, the Congressional Black Caucus, and the Congressional Hispanic Caucus. And each Congress, each of the caucus, takes priority to introduce the bill. So this year it was, or this Congress, it was introduced by Congressman Chuy Jesus Garcia, who's part of the Congressional Hispanic Caucus. And essentially what the bill does is that it, you can read it yourselves on this PowerPoint, but in short, it increases data collection and reporting, increases access to culturally and linguistically appropriate health and healthcare, increases access to mental health, and addresses social determinants and improves environmental justice concerns relative to health disparities. The Senate companion bill will be introduced next week, actually, by Senator Mazie Hirono as well. I don't have the exact time for when it's going to be introduced next week, but one of the most basic call to actions right now for senators in addition to telling them to not move forward a Supreme Court nomination, is that they should co-sponsor the Health Equity and Accountability Act. Since in the 115th Congress, there were only 10 co-sponsors of the bill in the Senate. Next slide. So again, this just gives a little bit of additional information about the bill. Basically, how, what some of the provisions do, right? So better data means that we can better understand the health disparities within our community, and it allows us to better address those discrepancies. The other thing that's not mentioned here with regards to data is that better data gives us better ways to advocate for our communities, because one of the key things that's missing from Southeast Asian American and generally Asian American and Pacific Islander advocacy is strong empirical data to sort of back up a lot of our narratives and our requests, right? We have strong stories, we have powerful anecdotes, but we don't have enough data to make a compelling case for members of Congress who focus more on data or who are likely to make economic arguments relative rather than moral and emotionally compelling arguments. With regards to addressing social determinants of health, really this is just holistically addressing the factors that affect health. So really developing the infrastructure to better just address health disparities amongst communities of color and other minority communities. And to the last point, appropriate services really just means, better serve and healthier communities. So if we have, more culturally and linguistically appropriate health services and mental health services, then, the women that Vattana and the Cambodian Family Community Center was working with wouldn't have to take 3 buses to meet the one Cambodian speaking mental health professional in Los Angeles County. In terms of general health priorities for SEARAC moving into 2021, we're at the end of the congressional cycle, and because it's also an election year, most members of Congress are really focusing most of their efforts into the election and the election outcome. That's why a lot of the big bills in other issue areas that we were expecting in September are being punted until 2021. So, because of that, we're also looking at our priorities with the eye to 2021 and the rest of the 117th Congress. And really, one of our main priorities is really just increasing access to affordable healthcare through the ACA and Medicaid. And this also means expanding ACA and Medicaid access to include undocumented immigrants, because right now undocumented immigrants are not eligible for Medicaid or access unless it's an emergency, and narrowly defined as an emergency as well. There are about 100,000 Vietnamese undocumented immigrants. So that means that sort of just off the bat, we know that 100,000 Southeast Asian Americans don't have access to health insurance because they're undocumented. The other key component for us is funding culturally competent mental health services. So in March, when Congress passed the CARES Act, which is at this point, Coronavirus Relief Bill 3, they included significant funding for mental health services, mostly around, drug use and COVID-specific support, but none of the funds that were allocated were, they didn't include any real language around making sure that the funds were being funneled into anything that was culturally or linguistically appropriate for minority or underserved communities. So a big part of what we're trying to make sure is included in future congressional, in Congress, is just making sure that culturally competent and linguistically competent mental health is funded, including in schools. And then, of course, reducing Southeast Asian healthcare disparities through supporting and reintroducing the Health Equity and Accountability Act. And really, this encompasses a lot of our work around language access and data segregation as well, which is a pretty common theme across all of SEARAC'S policy and advocacy work, and generally across the entire sort of AAPI policy and advocacy spectrum as well. And then the last component of our health work really is just increasing access to social safety net programs, like protecting and increasing funding for programs like SNAP and WIC. So I'm going to talk just really quickly about COVID-19 and Asian Americans because we don't have this aggregated Southeast Asian American data. So we know that to date, over 200,000 Americans have died from the coronavirus, and there are more than 6.8 million cases in the US. We also know that despite the fact that, that Asian Americans generally have a lower absolute number of deaths because of COVID-19 compared to other communities, we're still disproportionately impacted by COVID-19. So for example, the city and county of San Francisco, in May, they had reported 1,754 COVID-19 cases. But they found that despite the fact that Asian Americans had less cases of COVID-19, they actually had a higher proportion of deaths to cases available. And it's something that they also found in 8 other states. And so this is just to say that we don't have good data for how COVID-19 impacts Asian Americans, but what data we do have has shown that COVID-19 does affect our communities, it does affect it disproportionately, and that the sort of media narrative and the narrative on COVID-19 hasn't been as inclusive of our communities as it should be. And then the next slide really just highlights some data from the Center for Disease Control that was charted by the Marshall Project. And this set of graphs is really the number of deaths that happened between January 2020 and like August 2020. And the reason why this is important is that despite the fact that, general COVID-19 data has shown that Asian Americans, aren't as impacted as other communities of color, the actual death rates in the United States show otherwise. So we know that, across that deaths amongst Black, Hispanic, and Native American communities have been abnormally high this year. But now we can also say the same thing about Asian American communities, is that it's been abnormally high for Asian Americans, and that there was a 111% spike in death rates compared to like the average in mid-May. And that overall, our death rates are actually very comparative to Black and Hispanic populations at around 35%. So all that is a long way of saying that our communities have been impacted by COVID-19. We are disproportionately impacted. We've had higher deaths than normal this year, and that it's just not being captured correctly or made available in public data. And so for COVID-19 relief, we wanted to also just flag some of our priorities for the COVID-19 relief bills that have happened this year, and then any that may happen next year. We're still pushing folks to push their members of Congress to to put out a comprehensive COVID-19 relief package for Americans. But to date, Congress has not been able to find a solution since the passage of the CARES Act back in March or May. Although there was some relief that was in the continuing resolution that was passed in the House a few days ago. So for us, our COVID-19 priorities are really, one, increasing immigrant access to healthcare. So this means clarifying that emergency Medicaid covers COVID-19. And by declaring that COVID-19 is a emergency within the umbrella of Medicaid, it would allow non-citizens access to COVID-19 testing, treatment, and eventual vaccines. As you had heard earlier, Medicaid currently doesn't allow undocumented immigrants to access unless it's an emergency. And this basically is just getting Congress to clarify that it is an emergency, and that everyone who is present in the U.S. should have access to testing and treatment to isolate, to minimize the impact of COVID-19 as much as possible. And ultimately, we want to eliminate the immigration restriction on eligibility for health programs overall. Again, we want to disaggregate data and increase language access. So this means requiring that the CDC translate materials into 39 languages identified in the Department of Homeland Security's 2012 Language Access Plan. And the reason why we refer to the Department of Homeland Security, despite the horrendous things they've done, is that on record, they technically have the most sort of comprehensive language access plan of all the US departments. In 2012, when the Obama administration required that each of the different departments put together a plan. And so that's why we use that number. It's much higher than what most agencies and most departments try to utilize or try to translate. And then some of the other pieces include just addressing in-person communications needs, particularly at COVID-19 testing and treatment sites. And again, disaggregating data collected and reported. And then, it's not mentioned here, but also making sure that the infrastructure that the CDC is creating for data collection and reporting is also inherently has a disaggregation frame, because a lot of the language around data collection in the CARES Act didn't include a requirement for them to disaggregate the data at the point of collection. And then, for us at SEARAC, we also think it's important to just make sure that we increase relief to families. So making sure that, all American residents have access to stimulus checks, bolstering our unemployment programs, restoring the moratorium on housing evictions, granting immigration relief, and increasing immigration funding. And really the last thing that we really want is just, Congress needs to pass a robust COVID-19 relief bill, not the skinny one like the Republicans had introduced a few weeks ago, but a comprehensive bill that, allows all Americans to thrive. So before I move on to the next section, just gonna pause it to see if there are any questions. There's a lot of information. Feel free to unmute yourself and just ask if you want. So we have a question from Tuo Zhang, I believe. Is SEARAC doing any federal advocacy to ensure Medicaid works with providers of color to ensure services is accessible to community members? And he said, they said that we've seen and heard of providers choosing to go private because of complex and unnecessary processes working with public insurance. I'll just say that we haven't focused much on that specific piece. We generally leave that technical area of expertise to our partners at APCHO and the Health Forum and the organizations that work directly, that have community health centers that they're working directly with. On our end, our focus is really around funding increases, language, and data segregation. And to the best of our ability and to the best of our capacity, we uplift and support other health initiatives as it comes across us and at our partners' requests. Awesome. So moving into the next section, meeting your legislator. So this is something that I have done for a long time. And if you have any questions, just jump right in. I'm not mean most times, but I wanted to start with really quickly going over what your legislators can do. And, I want to emphasize that a lot of this is focused on grass tops lobbying and advocacy, but this skill set is transferable to local and state advocacy work as well, and can work within the context of, meeting with city council members, school board members, mayor, governors, and whatnot, right? It's a similar set of framing and that you do throughout this entire process. So in terms of what congressional members can do, they can make laws, right? Members of Congress can write new laws, they can amend and change existing laws. The way that a bill is passed generally is that one chamber of the House will introduce it, it'll go through a committee, and then it'll go to, if it passes committee, it'll go to the floor for a vote. And then the Senate will introduce the other branch of Congress will introduce their own version. It'll go through committee, and then it'll go to the floor for a vote. And if both bills pass, it'll go to conference, and then it goes to the president, who signs it into law, and then it becomes law, right? Congress sometimes does that. They haven't had a formal conference process for a while, but a lot of the processes are still the same, and there are multiple avenues where, if say, Senator Mazie Hirono introduced the HEAA next week, and the week after it goes to a committee for a vote. You can try to change and amend the language in committee as well. So, just to say that members of Congress have, multiple different opportunities to change bill language up to bill passage on the floor. Other things that members of Congress can do is that they can, to a certain extent, regulate laws. So they can, require and request regulations be created. They can request reports and evaluations from agencies. They can hold oversight. They have oversight of different departments and agencies. So, they can, ask why the Department of Health and Human Services is spending money on separating or on helping to separate kids at the border, but not spending it on pushing for Medicaid expansion in another state, or decreasing the uninsured rate. They also have power over the national purse, so they can fund programs, they can appropriate programs, they can create new funded programs, and generally they're the ones who control the money, right? They can also investigate new ideas, so commission research, host congressional briefings, they can create subcommittees. In some of my past work, when we didn't have enough data, we would work with a member of Congress to try to get a Government and Accountability Office report through the congressional process to try to get the government to get our data for us. Other things a member of Congress can do is author op-eds, so they can influence public opinion. And one dirty little secret is that a lot of members of Congress don't write their own op-eds. A lot of their op-eds come from their staffers either ghostwrite it for them, or they work off or are ghostwritten by community organizations, nonprofits, and advocacy organizations as well. And so, when you meet with your member of Congress and you want them to write an op-ed, just come with an op-ed ready, right? And then, they also communicate with their constituents. So, very basic requests that can be made of members of Congress, if you're from a nonprofit, is to have them host a town hall with your members and with their larger community, have them come to an event that you're doing, have them write letters of support for your nonprofit for various things, or for individual cases that might be happening. And they also do direct case management. So, oftentimes members will work directly on deportation cases. They'll have their staff investigate the deportation cases or other cases as they come up and as are requested by their constituents. So, there are a lot of different ways and areas for engagement with your members of Congress. And oftentimes they love doing the local stuff because members, one of their major priorities is one, that they look and sound like they are responding to their constituency, to diversity within their constituency, and members, generally care more about the optics and the stories, and staffers generally will care more about, will handle like the policy and the technical pieces and the nitty-gritty pieces of policy making. So next slide. In terms of just scheduling your meeting, it's very basic. Just going to walk you through like how you would request a meeting. So if you want to request a meeting with a member of Congress, you call their district office if they're in recess, right? So sometimes there are portions of the year where members are not in DC, and this is generally called recess. And they'll be back in their home district, and that's when you would call their district office, ask for their scheduler, and get the email of their scheduler, and then you just sort of have a back and forth with them about finding a time and making a request to meet with a member of Congress. If they're in DC, you call their DC office. And generally you can find this information online. You can just Google House and Senate recess and you'll generally find the calendar. And generally it's updated in mid-January every year. If you want to schedule a meeting with a staffer, and sometimes you do because you want to talk about and focus on the policy rather than the story or the optics of it, you know, it's a very similar process. So you'll call their district office if they're during recess to meet with district staff, right? Like if you're in Minnesota and you want to meet with Senator Tina Smith, you'll call her, and she's back home. You'll call her district office, talk with you know, their district staffer to get your concerns addressed with the senator. If you're in DC, you ask for their DC staffer, and specifically you want to make sure that you're asking for the staffer who handles the issue portfolio. Otherwise, they might punt you to like an intern or like another staffer who knows nothing about the issue. And then, you know, you just want to email your the staffer to arrange a meeting as well. And one thing that you want to do is just insist on video teleconferencing during the meeting, especially during COVID-19. Right? A lot of staffers will try to do just a telephone conference, and what you actually want is the face-to-face interaction, because you can't have the person-to-person interaction anymore. So you just want to push for it. They generally don't say no, but because people don't ask for video teleconferencing, they don't get it. So if you're requesting a meeting with a staffer, just ask for a video teleconference. It's generally works better than just a telephone conference, unless you're already working on a project together and you're just going back and forth. So in terms of if you want to prepare for a meeting, you know, basic things is you just want to know your elected official. You want to make sure you have an agenda. You want to know your issue. You don't have to be an expert. There's no expectation that you, a constituent, are an expert, but there is the expectation that you have an underlying understanding of the issue, right? Like know the basics. And most importantly, you have to know what you want, right? We call this the ask. So if you don't know what you want, you're just wasting everyone's time. Right? Like your time is limited, their time is limited. You want to make sure that when you're in the meeting, you know exactly why you're there. And there's no one's telling themselves that otherwise that you're just there to chat, right? You're there specifically because you want them to do something. So, you know, really basic do's and don'ts. Do's, have a conversation. You want to make sure that in your first meeting in particular that you're having a conversation. It's 60-40, right? Like 60% you talking, 40% them talking. You want to be able to ask questions, get answers, and you just want to be generally respectful of them. Like they're humans too, and they're people and have feelings. And part of the reason is that, you know, the first meetings are generally about establishing relationship and repertoire with each other. And the goal is that you're going to create trust amongst each other, so that they can come to you and you can come to them, and that they can trust your advice and your recommendations, not to, you know, turn it into action, right? In terms of don'ts, you know, the first and foremost one is don't lie. I've been in meetings in my past life at different jobs where people have lied. You usually get caught. Don't lie. You lose all trust. It's really hard to repair those relationships. If you don't know, just say you don't know. It's actually a really good opportunity to follow up because it gives you a reason to go back and keep lines of communications open. You shouldn't be mad if you don't get to meet with a member of Congress, and if they've punted you over to a staffer. Sometimes staffers are also equally important in the decision-making process. They oftentimes are the ones who will make the actual recommendation for whether or not a member of Congress should engage on an issue or take a specific stance on an issue, generally because they have a more of an expertise than the member of Congress does. And then the last two pieces are they're pretty self-explanatory, but I've also seen them happen before. Like, you shouldn't expect a staffer to resonate emotionally with your meeting or with your story. If it happens, it's wonderful, but for a lot of offices, there's an expectation that they keep pretty neutral looking about everything, even though they may, internally really resonate with the issue. And the last piece is just don't threaten the member or their staffer. I've been in a meeting where someone has threatened a member of Congress and they just walked out. That member just was like, I'm not going to be threatened. I'm out of here. Don't come back, right? You don't want to be blackballed from the office or blacklisted from the office. And this could be as simple as you being like, if you don't do this for us, we're gonna try to make you lose your election, right? Don't do things like that. So in terms of the actual meeting itself, and I'm gonna keep it short to just make sure that we have time for Q&A. So for your meeting, there are very basic things that you need to just keep in mind that you want to make sure that you're hitting. First, you want to make sure you introduce yourself. You'd be surprised how many people don't introduce themselves. You'd be surprised how many people don't identify themselves as a constituent. So you want to say, hi, my name is Com. I am a constituent of Senator Amy Klobuchar, right? Or whoever. You want to make sure that you clearly identify the issue, the problem that you're trying to address. If you have any relevant data, you want to make sure that you also bring that up. And then, you want to, especially if you're a constituent, if you're doing a first-time meeting, if you're a nonprofit group who, is really just trying to get this issue on your members' radar, you want to come in with a good story, right? People will forget the data, but they remember strong emotional reactions. So Vattana's story about the woman whose two children were removed, who could not access mental health services to get her kids back, who had to take 3 different buses to get to a provider. That is a really compelling story that helps make your case. It does not all have to be doom and gloom. It can be very uplifting stories, but you just want to make sure it has an emotional punch. And then the last piece really is, again, your ask. And this is going back to the slide on what members of Congress can do. And then following up is really simple. Just send an email, right? You want to make sure after you meet with them, you send an email. They meet with, a ton of people a day. And if you, do not keep in contact with them, if you don't follow up, they'll forget who you are. They'll forget your issue because they're inundated with so many other competing priorities as well. So you just want to make sure that you email. You want to make sure that you follow up in your ask. If you're like, I want you to do an op-ed, make sure you follow up and say, hey, so about that op-ed, have you talked to your boss about it? Are you doing this, member? Senator Tina Smith. And really, a lot of this is about helping you just build that relationship, keeping the lines of communications open, so that you can go to them for other issues as well. So framing, so I don't think we'll have time for small groups. Sorry, I miscalculated, my bad. I'm gonna talk really quickly about framing the issue, give an example, and then just go to Q&A real quick. But in terms of, you also want to think about how you're presenting your issue to a member of Congress or to their staffer. And this is really about just making sure that the issue resonates the most with, as much as it can with them. So you want to just consider what the member of Congress's background is, what the Southeast Asian population in their state or their district is, what they personally care about, what their history on the issue is, what industries are important to their state, and what caucuses and committee that they belong to, right? When I first started doing advocacy work when I was 20 years old, I used to interact often with this lobbyist who would tell me the story about how every time she would lobby a specific Republican senator, she would always bring a pastor with her because she knew that he was extremely religious, and so framed everything that she was doing through a religious or a specific Catholic context, right? So next slide. So to just give you an example, this is Senator Amy Klobuchar. I used to be from Minnesota, so I know her well. But she's a former prosecutor, so she's tough on crime. That's part of her handle. She's a moderate Democrat. She also just recently ran for president and dropped out. She's sympathetic to women and children. That's a particular angle that resonates most with her. We know that she didn't support the health equity, the HEAA in the 115th Congress. We also know that while she believes in universal healthcare coverage, she doesn't believe in concepts like Medicaid for all. She's also part of the Senate Judiciary Committee, and she's part of the Caucus on Women's Issues. So if I was to meet with her, I would say, "Hi, Senator Amy Klobuchar. My name is Kam Mua. I used to live in Minnesota, no longer live there, but my entire family is there. And, my friends, my families are all still constituents of yours. And we talk very frequently, and these are issues that they often tell me about. Today I really wanted to talk to you about culturally competent healthcare and mental health access, which is incredibly important for Southeast Asian American women and children. Without staff and practitioners who can provide in-language support, many individuals have to rely on their relatives or what little support they have to provide them with basic necessities, like translating for them when they need to go to the bathroom, get water, or eat. Hmong Americans are a large percentage of the Minnesotan population. We know that 1 in 4 Asian Americans are Hmong American. We also know that this population has 27% of this population is limited English proficient. The HEAA would not only disaggregate health data, but also allow us to better understand our communities and provide better language access support for limited English proficient patients. So really that's just covering, so that was just really covering introduction, issue, brief data, right? And then, if I'm meeting with a member, I especially want to do a story. So I'll say something like, when my grandmother was diagnosed with COVID-19, she was moved to 1 of 2 hospice centers that took elderly COVID-19 patients. No one there spoke Hmong. My extended family had to constantly be on a video conference line with her to translate and make sure that she could eat, use the bathroom, and get water. She became so depressed because of her inability to converse or even ask for her basic needs, along with the pain of COVID, that near the end of her stay, she constantly talked about how she should have just died. Luckily, my grandmother survived, and my family was large enough to have someone present with her from the moment that she woke up to the moment that she went to bed, but that shouldn't be a requirement for Hmong American families or other Southeast Asian American families who are limited English proficient. Every patient should be able to have to ask for basic necessities and treatment without having to have their entire family act as an interpreter. And HEAA would have helped my grandmother, and that's why you, as my senator, need to support this bill and this issue. And then that's a story, and so you move on to your ask, and you say something like, if you're meeting with a staffer, you would say, will your boss co-sponsor this bill? And the likely answer the staffer will give you is, I need to talk about it with my boss first. But you can ask, it also opens up an opportunity for you to have a conversation, like, what are the other health priorities of your boss? Are there other materials we can give you about this? Have you actually read the bill? Do you need me to explain it to you? Things like that. If it's a member of Congress, you just ask them directly, and they'll either say something like, yes, no, or, I really appreciate you bringing this important issue to my attention. I need to talk about it with my staff first, but you have my sympathies, and, truly would not wish this on anyone. Something like that, right? Like pretty generic lines, but it just allows you to just follow up with folks. So essentially that's framing. That's how you frame a conversation. That's how you frame an issue to a member of Congress. If we have more time, we do a mock and a small group, but we don't. So, unfortunately, this is time. I'm going to open up for Q&A. If you have any questions, feel free to just ask me or chat away in the chat section.
I have a question. My name is
Mhm.
Ben. I'm a student. I'm not with an organization or anything like that. First, I really appreciate the very specific strategy, tactics, and skills that you put on paper. I think it's great. It helps me imagine, and then plus your example. Would there ever possibly be an opportunity to see how this gets implemented? Like, take for example, I know you've already given an example and things like that, but if you ever are on these type of meetings, particularly now that we have Zoom, that either one of us who have a particular interest on whatever topic that you're trying to pitch could also be in that meeting. I mean, even if it's, for example, if I take notes, right?
Yeah, honestly, if you're interested, let
Yeah.
us know. One thing that we've been starting to do more is actually just bring constituents to congressional meetings with us.
Okay.
Mostly because, it's always good to have constituents. But two, because everything's virtual, there's less of a headache trying to get them to DC for these meetings with the DC staffers. So, if you're like, I have a member of Congress, I want to talk with them about this issue. Can you hop in this meeting with me, or can you help me with this meeting, or how to set it up? I think our policy team would be more than happy. I think depending on the issue, it'd either be myself, Nari, or Anna, or Mandy.
Great. I put my email in the chat right there, so I'm not too sure who would be picking it up or should be picking up, but that's my email. I'd love to pitch in wherever I can, and also learn, of course, learn how this is done.
Yeah, let me, I'll put my email in the chat as well, so that, folks who are, it's at the end of the slide, but if folks are interested, they can, email us or email me, and we can go from there. You can also find our emails on our website. I think it's in the About Us section.
Great, thank you very much.
Awesome. Any other questions, like burning desires that you just have to get off your chest right now? Well, if not, thank you so much for being here and for being part of our health advocacy training. I hope you were able to gain as much from it as we were able to gain from being in community with you. And if you have any questions or comments, feel free to email me, Gina, or the rest of the SEARAC team. We're always happy to follow up, take questions. And like I had mentioned to the previous comment, on our end, if your organization or you as an individual are interested in advocacy work, our policy team is more than happy to help provide technical support, or even just bring you on as an escort to congressional meetings if we're planning a meeting together with your member of Congress. Thank you, everyone. Take care.